Dr. Jithma Abeykoon, and he's going to be speaking about prescriptions for a rare disease. Is there a cure? He hails from right here at Mayo Clinic, and his research includes rare blood cancers, including ECD. His ultimate goal is to deliver passionate care for patients while conducting research to advance science and discover new treatments. Dr. Abeykoon.
Good morning, everyone. Hi, I'm Jithma. I'm a hematologist at Mayo Clinic. So today we will be discussing about Erdhiem-Chester disease treatment, and then we will discuss about if there is a cure from the current existing treatment strategies. So this is the outline. We will have some introduction, and we will introduce a case, and then discuss treatment strategies through the case, and then discuss about the cure. So I have no disclosures, but this is not the slide set, I think. 1 minute, I know what to do, I think. It's fine. This is the different slide set. No, it's fine. Okay. All right. Here we go. So this is the evolution of ECD for the last 93 years. So first it starts in 1930, and then during this time, it was an inflammatory disease since 2000 until 2016. After that, it became a cancer. The reason that it became a cancer was that because of the great discoveries that led by all these great people here, because we identified that there are mutations, BRAF V600E, MEP kinase pathway mutations, that comes and occurs in a cell, and these cells give rise to the cancer, which we call now the ECD, Erdhiem-Chester disease. So during this time, so from 1930 to 2016, it was an inflammatory disease, and now it's a neoplastic disease or cancer. And we have studied about 15 or so treatments during this 93 years. And some are not targeted. That means some are chemotherapeutic agents, immunotherapeutic agents, and some are targeted, meaning that targets a specific alteration or mutation. So we don't need to go through this because we just discussed this. So now I really believe that it is important for us to diagnose and so to understand what are these mutations, because the treatment actually is focused mostly on these mutations. So I will try my best to actually help you to understand it is not only the name of the mutation, what does it cause to a cell. So this is a normal cell. You know, you can see the plasma membrane here. This is the nucleus. This is like a section of a cell. This is the DNA. So in normal healthy cell, right, you have it right now in your body, there are signals. The normal signals function in the physiologic environment, normal in physiologic environment in yellow. These signals, it's a signal through receptors, and they bind to the receptor, and then the receptor signals downstream proteins, and these proteins give a message to the nucleus saying that, hey, now it is time to divide. So the cell gets the signal and the cell divides. And it is appropriate. It is actually appropriate and physiological. So that is the normal function of a pathway. So you can name this. These are protein names of the protein: RAS, RAF, MEK, ERK. You can name this as Pol, Sera, or whatever you want, but just want to give a concept that when you have a signal, it goes through a pathway and activates the DNA. So what does the mutation cause? So this is the mutation, mutated non-physiologic way. That means when you have a mutation in the BRAF or MEK proteins, you know, they no longer depends on the signal that comes from outside of the cell. They can constitutively signals the nucleus to give a false signal to the cell, say like, hey, now it is time to divide and divide and divide. So they are no longer depending on the yellow signals. Now they are more mutated, so they don't depending on these receptors, and they go downstream to divide. So that is why when these cancer cells, it can go to anywhere. It can go to your brain, heart, bone. When they divide in a closed space, you get the clinical signs and symptoms. When it is in the bone, you get bone pain. When it is in the heart, you get heart problems. When it is in the brain, you get brain problems. So that is the basic physiology or pathophysiology of the disease. So that is where we develop these treatment strategies, where if the patient has a BRAF V600E mutation or alteration in this protein, we can eliminate that, or we can target that through the drug called vemurafenib. And if there is a MEK protein mutation, we can target through cobimetinib. So these are the proteins, these are the drugs that can be used to target a specific alteration that happens in a patient. So this is the paradigm of mutations that happens in the Erdhiem-Chester disease, mostly BRAF V600E, and then you will have other pathway mutations like MAP kinase pathway mutations, and about 5 to 10% of patients will have no mutations in this patient population. So let's meet a patient. This is a true patient. Actually, I obtained the approval from the patient and to explain this. So through this presentation, I would like to highlight some key important concepts in managing and caring for patients, and then we will talk about treatment strategies. So 22-year-old female with central nervous system involved Erdhiem-Chester disease. In 2017, this young lady presents with severe headaches. The reason for the headaches was that the pressure in the brain increased so much because she had the disease in the brain, so that when the pressure increases, brain screams and say like, I have to give you a headache, and the patient gets a headache. So then she was managed through what we call a ventricular peritoneal shunt, where you put a shunt from the brain to the tummy, where you can equilibrate the pressure from the brain. So time goes from May 2nd, 2019, from November 2017, and here no diagnosis was made until then. And then we did some imaging studies, and the brain imaging and the spine imaging, which showed the disease involvement. And then we did a biopsy on May 14th, 2019, and here we go, the diagnosis was made. It was Erdhiem-Chester disease. So under the pathologist eye, it was Erdhiem-Chester disease. And then on the radiologist, by collaboration with radiology findings, pathologic findings, we made the accurate diagnosis of ECD. So let's get a step back. And these are the treatment strategies. You don't have to remember anything of this because your doctors will make the decisions with you. But what I want to highlight few important concepts. So when a patient has a disease, the first question we'll ask is, are there any appropriate clinical trials? Because this is a rare disease, we need to find more efficacious treatment strategies, and based on the design of clinical trials, it will never do harm for patients. So first we ask the question, are there any clinical trials? If you don't have any clinical trials, then we ask the question, are there any mutations? The same mutations that I mentioned during the previous slides. If there is a BRAF V600E mutation, we can use something called a drug called vemurafenib, which is FDA approved. If there is a MAP kinase pathway mutation, we can use the drug called cobimetinib, which is FDA approved as well. And if there are no mutations, then there are a whole host of other treatments that I explained in previous slides as well, that have been tried in patients. Some have been prospectively studied in clinical trials, and some are in case reports because the disease is very rare. I want to highlight one thing. When we treat the patients with based on the mutation profiles, these drugs are continuous treatments. That means the patient will be on these treatments as long as the disease responds or the patient develops adverse effects. So he or she will taking this medication until the endpoints have been achieved. The endpoints would be the patient develop adverse side effects or the disease is not responding anymore. There are certain other treatments that are fixed duration treatments. So that means you will give about 2 to 6 treatment cycles and you are done. And then you will be monitored with your provider for response assessment. So those are the treatments such as cladribine, cytarabine. Those are chemotherapeutic agents, but you will not be on this treatment for lifelong. You will be our fixed duration, 4 to 6 cycles, 2 to 4 cycles, depending on your provider and the preference, and then you will be monitored by them. So this is also not the slide set that I want, but anyway, that's fine. Forget about this comment section for now. But what I would like to highlight here is that these drugs have been studied in prospective clinical trials, vemurafenib and cobimetinib. That means the accurate way that the medicine will discover through new treatment strategies by treating patients. And some of them have been studied in retrospective manner. That means case reports and so forth. What I would like to highlight is that if we select these treatment strategies based on patient's mutation status, these drugs are very effective. You can see that the response rate is almost 100 for vemurafenib and cobimetinib. But remember that these treatments are continuous duration treatment. That means you have to take these treatments as long as the disease response. There are some other treatments that actually are fixed duration treatments, such as cladribine, cytarabine, as I mentioned, and they are also effective. About more than 50% response rates. So they are also effective, but these are all good treatment strategies, but those are the two paradigms that you have to think. One is a fixed duration and one is a continuous duration, because none of these treatments come without adverse effects. They have side effects. So you can see that on continuous duration treatment of vemurafenib or cobimetinib, most patients we have to start in a lower dose, number one. Number two is that 1/3 of patients will have to discontinue treatment due to side effects. Because the principle of treatment in medicine is that treatment of the disease should not be grievous than the endurance of the same. So side effects, we decrease the medication strength or discontinue it. And also about half of the patients will have to reduce the dose because of adverse effects. And these are the adverse effects not only with continuous duration treatment, but also with fixed duration treatment. They will get joint pain, rash, and these adverse effects will be further explained by Dr. Diamond in the next presentation. So the principle to take home here is that drugs are good. It will help you to manage the cancer, but at the same time, they do have adverse effects as well. It can be the chemotherapeutic agents or it can be the continuous treatment strategies. So back to our patient. So we know that we first have to ask, are there any mutations? So there are certain kind of tests that we do, that one of the tests called next generation sequencing, NGS. And unfortunately, when we first did tumor biopsy on this patient, we find no mutations, nothing. However, based on the NCCN guidelines at the moment, it is still okay to treat with cobimetinib or MEK inhibitor targeted treatment if you don't find any mutations, because some patients do benefit. So because of that, we started treatment with cobimetinib, and the patient unfortunately suffers with diarrhea, and we have to decrease the dose, and she did not respond well, no response. And then we went to a next line of treatment, which is the interferon, which is an immunotherapeutic agent to decrease the inflammation of your body. That happens secondary to the disease, Erdhiem-Chester disease. And she did not tolerate this well because the disease was progressing. And then we treat the patient with high dose methotrexate, the similar way that one will treat the patient with high dose CNS involved lymphoma, central nerve system brain involved lymphoma. After 6 cycles of treatment, she did respond. However, soon after we discontinued treatment, she progressed. So February we discontinued, March she progressed. This is she. This is actually the imaging of her. You can see that in the spine, disease was heavily involved. The black spots are the disease. And you can see in the brain, the white spots here are the disease, also here. And this spine here, the black is disease. So she has heavily involved disease throughout the spine and the brain. We did the second biopsy of this tumor, of her treatment, because now of her cancer, because now the patient is progressing after going through all these treatments. And the second biopsy also showed no mutations. However, we found that there is, in a variant of unknown significance, we found something called a CSF1R, colony stimulating factor 1 receptor if it stands for CSF1R, variant of unknown significance, meaning that we don't know the significance of this alteration. However, we found it in her tumor. So this is her timeline of treatment, and then she is now progressing. And what is the next line of treatment? Because I told you there are certain other drugs that have been studied in case reports, and some clinical trials. So what is the next line of treatment? So we were scratching our heads and say, like, is it chemotherapy, immunotherapy, maybe a transplant, or maybe palliative or hospice? Because we don't know, because it was at the end, we didn't know what to do. So we decided to target colony stimulating factor 1 CSF1R variant, because we know that CSF1R is important in maturation of the monocytes that you just heard from Dr. Jacobson's lecture. So we thought that this might be involved in the disease. And so we want to study this mutation a little bit more. We actually, we can skip this. We went to the lab, we studied this mutation, and we identified that this specific mutation, this is the protein actually. This is the structure of the protein of CSF1R. This specific mutation can alter this protein from this orange to the blue. And that alteration could activate the protein and cause the cancer to progress. So we found that by studying this. And then while we are finding this, she was not doing well. She was completely paralyzed, almost paralyzed from her waist. She couldn't walk. She has severe nausea and vomiting, couldn't eat. So she was having cachexia, that means wasting. And so we need to start treatment as soon as possible. And we commenced on a drug called pexidartinib, which is targeting this CSF1R alteration. Few weeks after treatment, she was a different person. So now she could walk. She could not walk in the sense like she couldn't run a marathon right now, but she could stand, she could eat well. Only thing is like her hair turned white as a side effect from brown, but she loves it as well. So she loved the side effect. So this is her images. You can see from the disease complete response. And you can see here, white, no white. Black, which is disease. White here is normal in the spinal cord. So complete response. So today this month marks the 3 years of follow-up, and she is disease-free to date. And her mom is there as well. So thank you. So the reason that I brought this story is that the reason that she is being disease-free is because of her team. The expert clinicians, expert pathologists, expert radiologists, expert pathologists, molecular biologists, bioinformaticians, basic scientists, and this is the patient. And these are all expert clinicians and a basic scientist. So when your loved ones are being cared by a center or a team, it is very important to respect each other's talents and each other's knowledge, and make sure that you utilize and focus this patient-centered caring for these patients, because that is how we will develop the next personalized medical strategies for these patients. So that is important to highlight. That is one of the main principles, that no one is great alone. We are great as a team. So then let's switch gears and start to ask if there is a cure for this ECD. What is the definition of a cure? So this is the definition of a cure from NIH or American Cancer Center, where you can see that, definition is you are treated, you are not on treatment, and you are cancer-free. So that is the definition. So then it begs the question, can you achieve a cure in the continuous treatments? We know that when we discontinue vemurafenib or cobimetinib, most patients will progress back. 75% of patients the cancer come back within 6 months. But there are some patients where we treat with chemotherapeutic agents, such as cladribine or cytarabine. After 6 months of follow-up or 1 to 2 years of follow-up, there are some patients that cancer is not back yet, and the patient is not on treatment. So then it begs the question, is this a cure? Yet I'm not sure. It could be a cure, but I'm not confident to say that this is a cure, because the follow-up is too short. 2 years is too short. So in summary, ECD is a cancer with driver mutations. That means you have a mutation that leads to propagate the cancer. There could be other mutations that we need to focus, such as the CSF1R and so forth. In treating patients, you have to focus on continuous duration treatment or fixed duration treatment or combination together in future treatment strategies. And there is unmet need to find new driver mutations and understand the biology of the disease a little bit more. And now, as Dr. Goyal will point out, the patients live longer. So the survivorship is critical. Caregiver support, social determinants of health, also, cancer screening, healthy living habits are very critical, because now our patients live longer with us, so that we need to make sure that the other spheres of health is managed well as well. With that, I thank you for all the providers and physicians. Thank you.
Thank you, Jithma.